guest speaker introduction today. It's very nice that all of you could join us. The WRTC seminar series is held every 2 weeks through the fall and winter semester, and we have a variety of speakers who come and speak about applied health services research and the policy connection. And the students who are part of the Western Regional Training Center in Health Services Research are focused on that applied health services research content and learning about it through the variety of guest speakers that we have. And I'll turn it over to Basola, who's going to do the introductions for us today.
Thank you. As Lisa has said, my name is Basola, and I'm a WRTC student and PhD student here at the University of Saskatchewan. I have the honor of introducing to you our guest speaker for today. He is in the person of Dr. David Poulin. He graduated with an MD degree from Marchildon University and family medicine residency from the University of Western Ontario. He had his mini residency studies in occupational medicine at the University of Cincinnati. Dr. Poulin has certification in family medicine and emergency medicine from the College of Family Physicians of Canada. In addition, he has worked as a family physician in Northern Ontario, emergency physician in Southwestern Ontario, and occupational medicine physician in private and public sectors. He served as medical director for Dow Chemical in Canada, Sarnia, Ontario, for a year. Dr. Poulin served as medical director, Interior Health Authority, Kamloops and Kelowna, in Kamloops and Kelowna for 10 years, and Vice President of Medical Affairs of the Saskatoon Health Region for 4 years. He is a clinical assistant professor here at the University of Saskatchewan with the Department of Family Medicine. He is currently the Deputy Registrar at the College of Physicians and Surgeons of Saskatchewan, and he's responsible for the public complaints resolution process and providing medical support to the prescription review program. Please join me in welcoming Dr. David Poulin.
Thank you very much, and thank you very much for inviting me here, and hello to Regina. I can't quite see you right now, Regina, but I will be able to see you later when we do the question and answer. Actually, I am somewhat used to the video technology. When I was in BC, in the interior, we covered a huge territory with that health authority, basically the lower half of the province, and we had 32 sites that we would connect through video conferencing. That was our record, to have a rounds with 32 sites on. So I'm familiar with the process. But anyway, thank you very much for the introduction and for inviting me here. I should start off with a disclosure, a conflict of interest. I don't have any, particularly with respect to pharmaceuticals, although I won't be talking about that today. I will mention a few books later on. I just want you to know I have no connection either to the publishers or to the authors, no financial interest in those books that I'm going to recommend to you. My objectives here, and I got to do this, I think, I was given a fair bit of liberty here to do this the way I thought would be useful to you. So what I thought I would do here is describe how I use evidence to inform my decision-making. In clinical practice, although, as you heard from the introduction, I don't do clinical practice any longer. I'm an administrator, medical administrator. I've been doing pure medical administration for the last 14, 15 years now. But I still have to pay attention to the clinical world, so I need to use clinical evidence a fair bit. But I also need to use evidence in terms of policy and what's going on in the healthcare sector, and in fact other sectors as well that impact us. So I'll talk a bit about that, and I'll talk a bit about why sometimes we don't use evidence in our decision making. I'll give some examples of emerging issues in healthcare where I think health services research can help. Now, I need to tell you right now, there's no rhyme or reason to the examples that I picked. These were things that were probably most top of mind for me right now. There's a million things I think I could have discussed with you. And I would invite you actually during the question and answer or the discussion that we're going to have, if you have other areas that I didn't touch on, to please bring those forward. As I looked at this again last night, I thought, wow, how come I'm not talking about this or that? Well, I just realized there just wasn't time to cover all the areas, but I've picked a few things that I think are illustrative of what's happening right now and what I'm thinking about these days in terms of the healthcare system, and where I think we actually need some more research and some help from folks like you to help us as we move forward. And then I'm going to leave you with more questions than answers. And I'm going to thank my wife for that one, because when I told her what I was doing, and I said I'm speaking to a couple of rooms full here in Saskatoon and in Regina of faculty and research students, and I'm not an academic. I thought, what am I here to tell you about or give you answers to? And she said, well, why would you need to give them any answers? Aren't they here to hear the questions that you have? And they come up with the answers. I thought, that's brilliant. That's what I'm going to do. Okay, so I thought I'd start off with this topic. Again, I'm not going to cover this in great detail. I'm just going to give you an overview from where I'm coming from, and hope that provokes some opportunity for some discussion later on. There's a ton of literature on this. I'm sure that all of you are more familiar with the literature than I am on this. So I'm not approaching it from an academic perspective. You have superb faculty here in Saskatoon and in Regina that help you with all the literature and research that's been done on this topic. But I'm going to talk more from my perspective, a practical perspective. So here's what I know, and here's what I see and deal with all the time. And it wasn't hard to find things in the literature. This was one of the first things I came across, because we struggle with this, quite honestly. And I have to say, since I've been practicing medicine or been in the medical field, we've struggled with this whole area of how come we can't translate research into practice? Why can't we just do it as this headline of this, or this title of this particular article says? And it's proven to be more difficult than anyone could imagine. And again, if you're interested in this, and perhaps this is something you've been covering in your program, there is a lot of literature on this about the difficulty that we have in medicine. And I don't know if it's just unique to medicine. I think it is in some respects, of being able to translate what has been proven to be best practice into practice. Best practice in practice. That seems to be the challenge. I think maybe we're a little off screen there. I'll read that for you if you can't see it all. It says, it may take as long as 1 or 2 decades for original research to be put into routine clinical practice. Thus, the translation of research findings into sustainable improvements in clinical practice and patient outcomes remains a substantial obstacle to improving the quality of healthcare. And as I said, this is something I've been hearing about for decades. And those of you that are in research, Rain, I think you deal with this.
That's a relevant question. We run into that right at Saskatoon.
Yeah, absolutely.
And it's not unique to medicine.
It's not unique.
Nursing,
Well, I'm glad to hear that.
Physiotherapy, same kinds of, there's common rigidities.
And this particular article, and the reference is on the bottom there, so I'm sorry it's not showing up on your screen, but that's okay.
Is the reference not showing? There's a big chunk
Entire
that's not showing.
There's just a little reference, but I'll just bring up the next thing. I think this will show. So this was a statement out of this particular paper that I looked at. This translational hurdle exists despite a wide range of strategies for implementing research in practice that includes provider reminder systems, local opinion leaders, computer decision support systems, financial incentives. All these things have been tried to somehow accelerate the adoption of evidence, best practice, and yet we're still not there. Now, when I looked at this and I thought about this from my own experience, which one of those things would be perhaps from where I am standing, the one that would have the most likelihood of impacting the adoption of research. And anybody want to hazard a guess which one?
Computer decision support systems.
Okay.
I'd
You
say
would
the
you would think
local-
so.
Local opinion leaders.
Local opinion leaders,
Yeah, I would say local opinion leaders.
not financial incentives. If we
No.
pay docs more to, I mean, that's been tried. And we do have a number of strategies out there in this province and in other provinces where they were trying to incentivize the right things and the right behavior, particularly in the areas of chronic disease management, where there's a lot of evidence-based practice out there. Guidelines that have been promulgated by various groups, and we have the Medical Association and the government have tried to put incentives, financial incentives, to allow physicians to do more of those things, but doesn't necessarily translate into adoption. So what's my thought on this? Local opinion leaders. That's, I think, the thing that is most likely to influence. So Rain, as you said. Now, I would have preferred it to be computer decision support systems, because that works for me. That turns me on big time. I'm very computer literate. I'm a techie, and I'll talk a bit about that. How advances in technology and how things work currently have propelled me into a new era of being able to use evidence at my fingertips. But that's just me.
Well, you're ahead of the curve.
I'm a little bit ahead of the curve in that respect. But that doesn't work for the majority, and particularly when, and I'm an administrator. I'm a medical leader, and I'm not doing frontline clinical practice. The folks that are in frontline clinical practice, I think, are more influenced by the people around them. I would even go so far as to say that who they'll listen to are the consultants that they refer to or that they work with, or colleagues that they respect and send patients to, particularly for family physicians. If a specialist stands up and says, "This is how I do this," or even a family physician to a group of peers, a well-respected family physician says, "This is what I'm now doing. You know, I've read the literature, I've just read a paper, decided to change my practice and do this." Others will follow along, in my experience.
Well, it's because the opinion leader knows why the change is needed, but you're part of the resistance of going along with knowledge translation is first you got to convince everybody that the change is needed, or that there's something wrong with the existing system, or even it's not that there's something wrong with the existing system, it's that an even better way has found. And that's where you usually are, is that you're even ahead.
Yeah. So we're just here. Regina may not be able to hear because of where the microphones are placed.
Paraphrase, maybe we'll save that to the discussion point.
Yeah. But I think the point you're making there, if I can paraphrase, is that opinion leaders know why the change is needed and perhaps are a bit more savvy and are earlier adopters of things, and then the others will follow along. But I would have to say the others in the system know too. They read the evidence, and yet they don't adopt. And so why is that? And I'm not going to try to answer that question. I don't think I can today. So what I wanted to do was share with you what I use, what I look at these days, how I use evidence, and how I think Others in the system use evidence as well, maybe to greater or lesser extents. But just to give you a sampling or a sense of what's out there and what's used. So first of all, going back to the comment earlier about computer tools, this works for me, and the big advance for me has been this kind of tablet technology, the iPad, where I can now have, and others in the system can have evidence-based guidelines and even tips available right at the fingertips. And for me, that's made a world of difference. So this Up-to-Date is one of the products that's out there where it's a peer-reviewed process where the medical literature is scoured constantly and distilled into a set of recommendations and guidelines that clinicians can use on virtually any topic. And I use this an awful lot in my practice right now in the regulatory authority, where I do have to look at clinical practice of physicians. And this is one way that I can tell whether what is up to date.
I know home care is really trying to go that way here in Saskatoon.
Home care?
Yeah, electronic data capture system.
Yes. A number of areas are trying to capture data and use that data and use decision support tools like this to help them in their decision making. So home care you mentioned here in Saskatoon, there's others that are using this. Many, I would have to say, more and more frontline clinicians are using tools like this, and especially with the ease of use of things like tablet technology. The other thing that's quite popular now, and I don't know if you've heard or seen any of this in your readings, in your work, but POEMS. This was an acronym that was coined by some physician, I think in Hamilton, McMaster, and has gained widespread acceptance. It stands for Patient-Oriented Evidence That Matters. Because this was the one complaint that we were hearing, was that, sure, there's lots of evidence out there. We're overloaded, actually. It's information overload. And just because one study or two studies have come out that are saying one thing, if we rush to adopt things too early, then we're going to be changing it within weeks or months when the next study comes out. So we really only want to see the stuff that really matters, that's going to make a difference, that is practice-changing evidence. And that's how they're framing this now. So even in the Up-to-Date program that I showed you earlier, they talk about practice-changing recommendations, or that kind of thing.
And that was enough clinical evidence.
That was enough clinical evidence. It's become so validated that now the experts are saying, we think it's time to adopt this new practice. So that's where things like Up-to-Date or looking for poems, and there's a number of products out there, a number of publications out there now that express it this way. And that gets my attention. And I think it gets the attention of others saying, okay, this has been filtered. And some experts have said that this is something that we should pay attention to. I know you can't read it, but this one here is on otitis media. And the treatment latest sort of guidelines. And they're often on very basic clinical things that these things come out. It's too bad we're cutting off because the titles do tell you what I'm looking at here, but I'll tell you, this is the Cochrane collaboration. Is that something you all refer to? I bet you do. So now again, this is not something that everybody looks at, I have to say, in medicine. I certainly do, particularly for what's the latest in health policy and research that's been going on in those areas. There's a fair bit of clinical evidence that's revealed here as well. Some interesting topics come up that provoke discussion. In fact, I was at a meeting 2 weekends ago, and you're not going to be able to see this very clearly, but I'll just point it out here if the mouse works. You can hopefully see that in Regina. But this little article here, mammography screening, 10 years, reflections on a decade. So this particular article that came through the Cochrane basically is saying the evidence is still not clear whether mammography really helps. And the authors were careful to say, we think it helps, we think it reduces mortality, because we all want to believe that earlier diagnosis leads to better outcome. But the evidence is still, after all these years, and the work that's been done, it's not as compelling as we would like it to be, that it does do that. But the authors are very careful in their wording, but it really creates a lot of concern and a lot of angst, because we have a whole system out there that we've created over many, many years to say mammography is a good thing, and we should be encouraging more women to have mammography, to then to come along and say, we're not so sure that it helps, can stir up a lot of concern and controversy. So this is one area where we have to be careful, even though the evidence may be inconclusive. Do we change the whole system there? And I'm willing, maybe right now, Rain, but I know you're frowning. Maybe later on you might want to challenge me on that. But I'll tell you right now, a number of docs did see this.
It's challenging the question.
Let's leave it for the discussion.
Yeah.
So that everyone can.
We'll keep moving along here. This is another thing that I look at and my colleagues look at. It's the Longwoods publication series, and they have this one, Healthcare Policy. Is this something you look at? Quite a bit of good stuff in here, particularly on policy, obviously, that's the title. And so it is something we certainly pay attention to. As well, there's this one here. I love this cover. This is Healthcare Quarterly, same publisher, Longwoods. And this comes out, and most of us are looking at this as well. I see that Maura Davies is interviewed in this particular issue, or the CEO of the Saskatoon Health Region. But some good, and in fact, there's an article in this this particular one on care of the elderly and chronic conditions in the elderly that I'm going to refer to later, because this one caught my attention when I was preparing for this. CADIF is Canadian. What does it stand for? The Canadian Agency for Drugs, Technology, and Healthcare, and Health. And this is a very useful organization. I have used them to ask them some questions around technology, around new therapies, and said, have you researched this? And if they haven't, they'll sometimes do that for us, and that's been a great service to be able to say, we're wondering about something, and we need somebody to look at the literature for us, and Cadith will do that. There is a local office here, although I took out her phone number because it's not working, and I'm not quite sure what's happening there. But there is a local liaison officer here in Saskatoon for the province, for Saskatchewan, for Cadith, and that's who I've gone to, looking for some assistance. An example was we were looking at the question of aortic stents for aortic aneurysm repair, which traditionally has been done through an open repair, which is major surgery requiring ICU stay afterwards to repair somebody's aortic aneurysm. And this newer technique has evolved over a number of years, where a stent can be put in through an artery in a very minimally invasive way. which right off the top you think that's got to be better for patients, and it is. Less invasive, shorter hospital stay, less ICU, less cost to the system, but doesn't really make a difference to the outcome down the road. That was the question. So it's very helpful to have a group like CADA do that for us. Well, there's Beth Horsberg. This is another place that we've gone to, the for Research and Innovation Office, the joint office with the university and with Saskatoon Health Region. And there's a number of staff there that will do some research and have done research for me and my colleagues on various things. And that's part of their mission is on the bottom there, which is to do literature reviews, environmental scans, benchmarking. What you can't see, what's been cut off there, is health research dissemination and knowledge translation. So another good resource for us. So here's why I sometimes don't use evidence, and my colleagues. Even when the evidence is there, and we want to be evidence informed always when we're making decisions, and I'm sure you would like to think that we're always doing that, but there can be these other factors. Culture can play a big role. Culture of an organization. I think, what's the saying, that culture eats strategy for breakfast. So you've got to overcome culture, which I think in a way is another word for inertia, resistance to change. I think culture has firmly held beliefs. And I think in medicine that is very, very strong. The reasons that physicians and I guess nurses and other healthcare professionals don't adopt evidence and research too quickly is because the culture says, no, we need to go slow, we need to be sure, we need to wait 10 years, we need to wait till the people we respect and our opinion leaders are doing it, and then we'll do it. So that's what culture is all about. So if we can leverage culture, I think that's where the opinion leaders come in. Politics can play a role for sure. It can affect decisions. It can cause some decisions to go 180 just based on a political issue. I'm not saying that in a bad way. It just maybe politics is about priorities, right? Politics is the art of the possible, and so sometimes things have to be done because it's a priority issue with government or with others, and even though the evidence would suggest that isn't our priority, we should be doing something else first, that becomes the driver. And I hear this all the time. An example would be, right now the province has invested very heavily in surgical waitlist reduction, the Saskatchewan Surgical Initiative. Lots of good work, going to bring down surgical waits to 3 months maximum, and that's I think by 2012. If somebody knows, let me know. But I think it's a fairly aggressive target for the province. A lot of good work being done there, and I think they're going to achieve that. We're going to get those wait times down for surgery, because for government that's a big important thing. That's what they hear about a lot. But others say, but there's other priorities as well in the healthcare system that aren't surgery. And why are we not putting as much effort into those things? And why are we not spending as much as we are on this? And that's a political decision. It doesn't mean it's the wrong one. It's just that's the priority that we need to live with. And I think human emotion, and I deal with that too. And people will still make emotional decisions based on their own personal experiences and frames of reference. And even with evidence in front of us, sometimes decisions get made that way. So not necessarily the best way. I think we try to be more aware of that and try to challenge each other when we think decisions are being made emotionally, and try to go back to at the touchstone of more evidence-informed decision-making, but it does certainly happen, and even in the most senior levels of the healthcare system, it's a reality. So you need to be aware of it and not underestimate those things. Okay, so let's move on to some examples that I came up with, and like I said, this is just what came to me. The list, and you wouldn't believe what I had to cut out, because I just kept adding, and so I just very selectively, I obviously have some biases here, and I admit that freely to you. So there's lots of things that maybe should be on here that aren't. But feel free to ask me questions later if there's other things. But here are the things that I wanted to just cover off with you very, very quickly, and just tell you what I'm thinking about and what I think the system is thinking about right now. We'll start off with patient safety. This is a big one in healthcare right now. It has been for the past number of years now. Really, the Institute for Healthcare Improvement in the US, I think, really got the ball rolling. We have a Patient Safety Institute in Canada as well. These two papers were very important to Errors Human, 1999, out of the US, which I'm not going to give you all the stats. If you're interested, you need to go and read this. I think everybody should look at these, at the two Errors Human study, and then the Canadian one, which was the Canadian Adverse Events study done by Baker and Norton et al. Again, another seminal paper. That was 2004. So really, they found there are lots of bad things that happen in the healthcare system and hospitals, and they lead to adverse events and poor outcomes and even death. In the two Errors Human, when they extrapolated from the study that they did, they said there were 100,000 lives being lost in the US annually due to adverse events in hospitals. So things that happened to patients that were not because of their actual illness, but because of something that went wrong in the system, an error. Although we're trying not to use the word error much, and I'll talk about that in a minute, but an adverse event has occurred that's not directly related to the underlying medical condition that's caused harm. So that was 100,000 lives. In the Canadian paper, when they looked at a sampling of centres across Canada, and when they extrapolated their data, came out to about 10,000 lives, which makes sense. I think there's some relativity there between us and the US. So that led to the 100,000 Lives campaign in the US. Have you heard about that? So this is big. Like, you'll still hear about this especially if you're looking at any of the US literature, if you go to any conferences in the US, especially health improvement or patient safety conferences, they still talk about 100,000 Lives campaign. Really a set of evidence-informed interventions were recommended through that would, if everybody adopted them, would save 100,000 lives annually by eliminating adverse events that occur in the hospital system. In Canada, we called our program Safer Healthcare Now, and it was the same idea, a number of interventions that had been shown through research to be high risk and high volume. And those are the things we look at: high risk, high volume. Because if we can do something with that, we can make a bigger impact on the system. And so I won't go through them all in detail, but a number of different interventions and protocols and were developed and disseminated to hospitals across Canada, just like they did in the United States with the 100,000 Lives campaign. In fact, the interventions were very similar. And the whole idea was to try to get everybody to adopt these things. And this has been going on for a number of years now, and we're not quite there yet, but we've come a long way. And I'm happy to say that a number of these initiatives have been well adopted by the systems, others not so much. But the proof is there, the evidence is there, the research is there that if done, it will make a difference to patients. The one we're having the most trouble with is medication reconciliation. They found that a lot of errors were occurring in hospitals because patients it wasn't clear what medications they were on when they were first admitted to hospital, and meds got missed on admission or forgotten or on discharge. And so there's a whole protocol to do medication reconciliation that's come through this. That's a bit harder to adopt, and probably because more physician involvement with that one and a lot more work, and that seemed to cause more resistance. Anyway, I won't go into too much detail. If you're interested, look up Safer Healthcare Now. The other thing, the latest thing that's out there is a surgical checklist. The little thing at the top was a clip from The Guardian from January 2009 from the UK. A surgical checklist cuts deaths by 40%. So a checklist procedure in the operating room, not unlike what exists in the aviation industry for pilots, co-pilots, to run through a checklist. And now this wasn't normally done, and there was a fair bit of resistance, a lot of resistance from surgeons and nurses in the system saying, why do we need to do that? We know what we're doing. Why do we need to do a checklist? But it's been proven. This is a World Health Organization initiative. It's worldwide. WHO set out to make a difference around the world, and I have to say it's catching on. And here in Saskatoon, in Regina, and I think even in other hospitals throughout the province, more sites are adopting this and building it into their procedures. But not an easy thing still, because it means changing the culture. It's not what people have done before. The other thing that goes along with this has been the concept of open disclosure of adverse events. And that's why we're trying not to use the word error as much, because that has a medical legal connotation to it. What we feel now, and these are two publications. The top one is from the Canadian Medical Protective Association, basically the insurer of physicians, the ones who protect and defend physicians if there's a malpractice suit or a complaint. The CMPA has put out a publication that recommends communication and have an open disclosure to patients when there's been harm or an adverse event. And then the Canadian Patient Safety Institute that I mentioned earlier also put out a publication called Canadian Disclosure Guidelines. In fact, the Canadian Patient Safety Institute document informed the CMPA document. But it's, and this, I use these slides because I do some teaching for our new physicians who are coming to the province, our international medical graduates who are coming here, and we do an orientation for them to how things work here in Canada, maybe somewhat different from where they're coming from. And I talk a lot about this. This is my area of talk is about disclosure, about being open, about telling patients what's happened. And there's a whole algorithm to be followed here, but it's a good thing actually. Didn't always used to be this way. It used to be don't say anything, don't admit guilt. It's gone completely the other way, which I think is good. Okay, move on to another topic. I'm moving through these pretty quickly just to give you a little sampling. That's all I'm doing here. Quality improvement in healthcare is becoming a very big thing. And if you're going to be out there working in the system and helping the system, you're going to be seeing a lot on patient safety that I just talked about, and you're going to see a lot on quality improvement, particularly the lean, which is just one type of quality improvement process. Lean uses terms like value stream mapping, Hoshin-Henry, Those are all techniques. Do you know where this all comes from? Toyota. Yeah.
Private industry.
Private industry. You heard in my intro that I worked in the private sector for a while as a medical director. That was back in the 80s, the early 80s, in the petrochemical industry. And we were doing total quality management and quality improvement. And I was doing it there and adapting it to our healthcare part of the business way before hospitals were doing it. But then it came into the hospital sector, and it's been there ever since, and it's a big issue. This I've taken this off the website from Saskatchewan Health. That's cut off at the top, but this is Saskatchewan Ministry of Health, and a big push there to have lean and other quality improvement initiatives adopted across the province. And in fact, it's an expectation. And the government's investing heavily. Site visits have done. Consultants are being brought into the province from the United States to assist all of our health authorities with adopting lean, particularly lean principles of quality improvement. And Hosh and Canray, which I don't know a lot about, maybe some of you do, but it's more of a rapid cycle process of tackling big problems quickly in a very focused way, focus and finish way. But the whole goal here is to improve healthcare, and it was driven by the Patients First review that was done in this province, which says we need to do a better job because patients aren't feeling that they're at the center of care and that the system doesn't always work that well. And so we need to pay attention to that. So that's what this is all about. So as you look at the healthcare system, and if you are working in the healthcare system, you're going to hear a lot about this. So it's good. I would recommend doing some of the training around lean. I tell everybody that who's coming into the healthcare system, get some introduction to lean. Okay, some new technologies. And I just picked these because they're top of mind right now. So liberation treatment, that's for multiple sclerosis. That's the Zamboni procedure. And it's too bad we're not able to see all the things here on the screen, but this is a series of updates that were posted on the website at SHRF, the Saskatchewan Health Research Foundation, that was asked back on the bottom here in September of 2000 and at the top, October of 2010, asked to develop a call for proposals for an MS trial. This is when there was a lot of interest because of this procedure that was being done in Italy by Dr. Zamboni. It was anecdotally showing benefit to patients, and there was a real drive to see if we should be adopting this, and there was a desire by a lot of patients and clinicians to adopt this procedure even before clinical trials had been done to see A, if it was effective, and B, is it safe. So Saskatchewan was the first jurisdiction in Canada to say let's go move forward with some clinical trials at least, and let's put some funding towards that. We happen to have the highest per capita MS incidence, so that's good reason. The Prairie provinces particularly, we don't really know why that is, but we do. So they set out to do that. By December of 2010, the call for proposals was released, looking for research projects to come forward and be presented to SHRF for funding. There was $5 million set aside to do this. By June, they came to the conclusion, SHRF came to the conclusion that none of the proposals received should be funded. They didn't. I'm not quite sure why that is. It'd be an interesting project to dig into that a little bit, what happened there. But they did not feel that any of the proposals that had been received were perhaps going to answer the question, Might have been the size of the trials that were being proposed. I don't know exactly what it was, but they said we can't recommend any of the proposals. So you think that would be kind of the end of it, but by September of 2011, the government of Saskatchewan, that's the part you can't see here that's cut off at the bottom, announced that they were going to partner with a center in New York, in Albany, New York, to have a place where patients from our province who wish to participate in a clinical trial would have a place to do that, and that Saskatchewan would be a partner with that. And also Canada, the government of Canada has also recently announced, in the summer, announced that they would be investing in some clinical trial work at the national level. And that came right after Saskatchewan announced that we weren't going to fund any proposals. So there was remember I talked about politics influencing the way research is going, and this is one of those areas. Now, I'm not saying that's a bad thing, because there's many people with this disease, and I think this was important to move forward with this research. And it was that drive, that political drive, actually, that's having it move forward. So there's an example. Where I have to deal with it in my current role with the College of Physicians and Surgeons is now we have patients who've gone overseas or gone to the US or overseas to obtain the treatment because they want it so badly. These are people who are suffering terribly, and they were clinging to any hope. And so I've spent a lot of money and gone overseas, and they come back, and then there's some issues with the follow-up and treatment when somebody's gone away for a procedure that we don't really fully understand, that clinicians here aren't sure, or maybe even don't think should be done. And patients are coming back now having undergone that treatment, and they need some kind of follow-up. And we need to get involved when the patients have difficulty getting that follow-up. So if you're interested, I can talk more about that with some of the things that we've run into. That's where, again, research and new technologies meet kind of the real world. Here's one that's really interesting to me. Personalized medicine. Has anybody heard of that?
No, that's a new one on me.
I first heard about it just a few months ago when we were interviewing a new department head for our pathology lab medicine, unified department, academic and clinical department for Saskatoon. And this pathologist was asked about what usual questions in interviews. What do you see as the future, next 5 years, kind of thing? And he said, personalized medicine. That's going to be the thing we need to be paying a lot of attention to, because that's coming fast. And I didn't even know what that was, and most of the people in the room didn't either. So I looked into this. And first thing I went to the website for the College of American Pathologists and just followed some links and got to this lower insert there, patient pathologist consultations. And I'd never heard of that. Pathologists normally don't interact with patients. The pathologists are lab physicians. I mean, that's not entirely true. There's a few procedures that some pathologists get involved in on live patients, but most of the time, pathologists do autopsies, where they read slides, they read surgical pathology, or they're interpreting lab results and that kind of thing. It's very much a pure science that way. And here we have a training program now being developed by the College of American Pathologists on how to now start training pathologists to interact with patients and do consultations face to face. And this, if you follow the links on this website, you get to simulated patient encounters. There's a whole video program. It's quite extensive. Nicola, have you seen this? Have you heard of it? So what it is, or what's driving this? So here's a slideshow that I took off their website. They've got a number of webinars, and they posted their slides. And this was offered by one of the pathologists there, and personalized What is it? It's the use of the human genome. Now that the human genome has been sequenced, that was number one. Now number two is it's now practical. They've found ways to make it practical that many labs, most labs, can do it. The technology is out there now to sequence the human genome. And so what they're now saying, the people that are promoting personalized medicine is saying, if you can take human genome data on an individual patient, not on a group, not on a cohort, which is how our studies usually work. We look at cohorts and then we generalize, right? That's how evidence is usually done. This is done on the individual patient. And what you can't see under here is we can use the human genome data to optimize patient care by getting, first of all, the correct diagnosis, then the correct treatment that's been matched to that individual patient based on their own unique genetic signature. And even things like correct drug dosages can be calculated for that particular patient. So it's individualizing the care. And that's where pathologists want now, they're going to be consulting with patients based on their genome. And so here's an example. What you can't see at the top there is there was a title that said Futuristic Paradigm for Cancer Care. And then that's been crossed out. And it says Standard of Care Sooner Than You Think. And this is a whole algorithm of how patients will be referred from oncologists and primary care physicians and other specialists through this laboratory system that will map their genome and customize it to specific treatment for their unique disease. And the pathologists see themselves being the ones quite involved in that, and then developing a consultation report that then gets fed back to the clinicians to allow very precise treatment. So they see that right away applying in cancer care, which makes a lot of sense because right now we use chemotherapy and radiation in a very general way. This would be much more customized. So personalized medicine. So this is where catch stuff early and even into prevention. There's a whole bunch of things. And there's going to be some ethical issues that come out of this too. So if you're looking for an area that is going to be in need of some policy development and further research, this is going to be it, I think. Okay, another topic, care of the elderly. I see this a lot. Have real concerns. This was a paper that was in the policy, I think, or the health quarterly that I showed you earlier. And we have to start challenging some of our assumptions. There's an assumption there that every old person, as everyone gets older, they consume more healthcare. And I think that's generally true, but not completely. And this particular paper, and this is just one, is saying that it's actually the chronic conditions that you have that drives how much healthcare. That makes sense intuitively. But if you could be old, and if you don't have chronic healthcare conditions, you're not a big consumer or user of the healthcare system. But we all assume that everybody who's growing old is going to consume the healthcare system exponentially, and that's not quite true. It's really related more to chronic disease. So I think that's intuitive, but it's nice to see that some research has been done, and I think more is needed in that area because we just make a lot of assumptions. And when people talk about how the system is going to collapse and the system's in crisis, it's because there's this worry that as the boomers, me, and my boomer colleagues move forward, we're going to be massive consumers of the healthcare system because we're all getting old in great numbers. And that may not be necessarily a straight line or exponential as people fear. So I think we need to have some good research where some of those assumptions are looked at. And maybe you can help with some of that. So it's not just age, it's more chronic conditions. Now what I think has a lot to do with it is polypharmacy, number of medications that people are on. You've probably seen that. And you know, I think there has to be a limit where the number of medications and the combinations of medications that people are on, even though individually each medication is perhaps a good thing, it's getting very complicated, very complex to try to figure out the impact of somebody being on 10 or 12 different medications for different things. And we see that in the elderly, and it causes a lot of unintended consequences and complications in the elderly. But without good evidence out there, people just keep on doing that. Physicians keep on doing that. Our healthcare system is a bit fragmented with multiple specialists and everybody prescribing in their own little domain. And family doctors and nurse practitioners are the ones that need to put that together and look at the patients more holistically. But they feel a bit overwhelmed by all that, especially when specialists are saying, here's what's best. But I'm not sure this is what's best for our elderly patients. I also personally believe, and it's my own personal thought here, is that hospitalization of elderly is not a good thing. I mean, it's necessary at times for certain conditions where there really is no choice. You have to be in the hospital, but by and large, hospitals are bad for people, but certainly elderly. There's more things that can go wrong, and with elderly, particularly if they have any cognitive issues going in, if there's some dementia going in, that's exacerbated tremendously being in an institutional setting like a hospital. Because we don't adapt our hospitals to the needs of individual patients. They're there to serve the general patient population and more designed around the younger, generally healthy adult population. And so we have designed things around that. Acute care. 4-bed wards, those kinds of things that for if you're having a short stay episodic care, that maybe works, but for elderly who have complex problems, it doesn't work. And they get into more trouble, particularly delirium, which is often confused with dementia, but it's not the same thing. Delirium is an acute confusional state that can be brought on by medications or by the environment. Just being in a strange environment, by having your sleep cycle disrupted, which happens in hospitals. So I actually think hospitals are bad, and our system should be, for the elderly, by and large, and we should be trying to keep people out of hospital, yet our system is designed more to bring people into hospital. And we could get into a whole discussion why that is, but I think that's a problem. So I think more work is needed to be done to prove that and show to the system that we need to do a better job. And here's another area, end of life.
I'll just let you know there's about maybe 15 minutes or so left.
I'm just about at the end,
Okay.
right at the end
Just
here.
because I know you want to have discussion with people. Thank you
50 minutes for my part or for the whole thing?
for the session.
Oh, I'm sorry, I guess I've been going on too long here. So end of life care, I'll just mention that the headline here from the Globe and Mail was there are a lot of better places to die than Canada. And there was a rating system that somebody did, and Canada's number 9 on there. We don't do a good job on end of life care either. We're too acute care focused. And just this morning watching TV, there's a big meeting about hospice care. So, and this is another area that I think more work needs to be done. A lot of good work has been done about Aboriginal health in Canada. A lot of factors involved there: culture, epidemiology, socioeconomics. Self-determination is really important, I think. That's probably the number one big issue, and a lot being done there on self-determination. But I still think there are issues in the system with discrimination. I believe that's still there. And our health system, the way our health system is designed, is not culturally sensitive enough and does not adapt well to the needs of our Aboriginal population and others, and so I think we need to look at that more critically. I mean, we're doing a better job, like our new children's facility that's being built is going to incorporate a lot into its design for First Nations and Métis health care and cultural issues, but I'm not sure we're there yet, and I think we need to do a lot more work there. Professional self-regulation, maybe I'll just skip over that a little bit, because that's my own pet topic, because that's what I do now is self-regulation. And you can't see it anyway, but there's been a lot of questioning lately about the whole concept of professionals self-regulating. Is it working? Because we've had some spectacular failures in the system across the country, and so we're being quite rightly looked at and maybe criticized for, are we doing a good enough job in terms of self-regulation? Not just in medicine, but in other professions as well. And I think we need to take a look at that. Maybe we need some help, some research in that whole area to see, what are the benefits of self-regulation? What are the things? And I just ended with this, some of the books that have influenced me, just to share with you. If you have some spare time and you're looking for some reading, How Doctors Think is a great book. You're trying to figure out why doctors are so locked in to things and maybe why they make mistakes, and it's a good book. Switch, How to Change Things When Change is Hard. If you haven't read that, but it's a great book, very practical, actually. The Great Influenza is a really good book to read if you're interested in the history of medicine and how it developed. It really traces the whole development of the medical system. I mean, the backdrop is the Great Influenza of 1912, 14. But it gives you that whole history of how medicine came about. And then one of my favorite books is Mountains Beyond Mountains, about Dr. Paul Farmer, who's done incredible work with tuberculosis, HIV control around the world, starting in Haiti primarily, and that's a very inspirational book. How you can change. You know, he said, "I can cure the world," and that's what he set out to do. So, very good book. And I'm very influenced by Atul Gawande, a surgeon, and I read all his stuff when it comes out. Because if you ever have a chance to read any of his work, this one's Complications at the top, Better, the Checklist Manifesto. He's talking about the surgical checklist now as a surgeon, so another good book. Okay, here we are. Sorry, it took a bit longer than I